How's it going, everybody? My name is Luke Reagan, and today I'm going to be giving a presentation about the physician-patient relationship. The physician-patient relationship is a really important relationship in today's society, especially with the pandemic and whatnot. And basically what the author does is try to critique the nature of it and what the physician-patient relationship really should be. And a little bit about the author. His name is Terrence F. Ackerman. He's director of the Program of Human Values and Ethics at the University of Tennessee. And in his piece that we all read, Why Doctors Should Intervene, basically challenges this notion of non-interference that is the standard in the physician-patient relationship and feels that there should be a little bit more interference than there normally is. And the way he goes about doing this is first defining this term called autonomy. Autonomy he defines with two characteristics. First, it's plan of action through deliberation. It's me making choices that are thought out beforehand on my own terms. And they have to be intentional and voluntary. I have to want to do them. I have to be focused on doing them. And they can't be affected by internal and external factors. And when it comes to the physician-patient relationship, it basically boils down to the doctor respecting all the patient's demands, keeping all of their personal information disclosed, and allowing the patient to refuse what's best for them. Like, it's their own personal autonomy. They can do whatever they want, even if it's the worst course of action. But what Ackerman does is he challenges this notion because he doesn't believe that ill and injured people have full autonomy, because there are these internal and external factors caused by their illness and injury that can affect the way they make decisions that normally wouldn't happen if they weren't ill and injured. And he thinks the doctor needs to really do something about this. An example from my own life. Recently this summer, I tore a muscle in the back of my neck. It was very painful, very excruciating, and more so than I thought it would. It really altered the way I lived my life because I had this injury that barred me from doing a lot of things that I normally would do on any given day. Some examples: I couldn't drive long distances. I was really kind of just stuck at home, couldn't really do much because it just hurt so much. My neck would hurt in the car. Couldn't sit for extended periods of time. And you think, like, what? Just the way my back would be positioned, I need to lie down and stand mostly. And I had these awful, really awful headaches, so I had to take so much Advil, more so than I really should have. And this really just describes how illness can affect autonomy. For me, it was physical, but it can also affect patients psychologically in forms of denial, fear, depression, guilt. And there can also be social and cultural expectations that are brought on upon someone due to their illness or injury. And one psychological example that the author gives: there was one patient who had abdominal cancer, and he was in denial of the fact that he wouldn't get better. The doctor said he wouldn't get better. The treatment isn't working. We have these clinical trials that might help you. They might cure you. We don't really know yet. But the patient refused them because he just kept saying, do whatever's going to get me better. And another example, a fear example, there was one patient who had a brain tumor in the article, and they didn't want to get the surgery because they had fear of getting cosmetic damage due to it being a malignant tumor. If they had done the surgery earlier, they would have found out earlier that it was actually a benign tumor, and the surgery would have gone swimmingly, but it didn't, and the patient died, even though they most likely would have survived. And another example from my own life, my friend Mike recently, 2 weeks ago, he got strep throat, and he grew up in a culture in his family that they didn't really value and respect, like, doctors' opinions or whatever. And so he would rather sit at home and stay sick for a week than get a Q-tip in his throat and get some antibiotics. Very strange, but that's how people can be. And then another point he brings up is that a lot of people don't really know how to fix themselves. They don't really know what to do, don't really know what they want. And so they just default to the doctor. They have no idea what it is they really want to be accomplished from visiting the doctor. And so they'll put all the decisions in the doctor's hands, and that doesn't help the doctor at all. And so this is really boils down to why non-interference is bad. The patient lacks full autonomy due to their illness. Their decision-making skills are impaired, and the doctor should not just stand by and let the patient do something stupid because they are impaired. They cannot make these good decisions. And it's really really negatively affect how patients are. And the role of the physician and the physician-patient relationship, that's what Ackerman argues. He argues it needs to change. The role of a doctor shouldn't only be to cure the patient of illness. It should be able to guide the patient to regain control over their autonomy and over their decision-making and over their self-control. And how does he figure they should do this? The doctor must adapt based on the patient's impairments. They need to treat patients differently based on how on a personal level that this illness or injury is affecting them. Because two patients might have the same illness, might have the same injury, but it's affecting them in different ways, psychologically, mentally, cognitively, and whatnot. And the author really stresses this cooperation objectivity. Objectivity is curing the patient, helping them to get better, but the cooperation is really getting to know on a personal level how the illness is affecting them, not only physically, but mentally, cognitively, physically, like I just said. And why non-interference is the standard. The author does acknowledge that there does need to be a certain extent of non-interference. It is a technically competent medical care in exchange for financial compensation, but the root of it, there should be no interest in each other, but there is, because it's a doctor. The doctor needs to get to know the patient and use their personal information to help them. And how it should be changed, the doctor shouldn't be just seen just as a business partner, just as a contractual agreement, but they should see more so as like a therapist. They should be able to use this personal information in any way that can help the client regain normalcy and gain control of their life. And understanding why non-interference is important, like I said, the author did acknowledge that it was very important because the physician ultimately has the advantage in this situation. They know way more than the patient does. They know how to fix the patient. The patient doesn't. That's why they're at the doctor. And it can be very easy for the doctor to take advantage of the patient, but that should be the doctor's prerogative not to do so. And final point, Ackerman is right. I do really feel that there should be changes in how the physician-patient relationship is formed. I do agree that illness and injury can affect autonomy, as I said so myself, and there needs to be strides in how this should be gone about. Thank you.